Okay, thanks, Peter. Hopefully you can hear me okay and see the slides okay.
Yeah.
So yeah, thanks for inviting me to share some updates on this upcoming trial with you and with PIRN. So as Peter mentioned, this is called Better Outcomes in Babies with Bacterial Meningitis Randomized Control Trial, aka BOBBi. So before we get into that, I just want to acknowledge that I'm extremely grateful to live and work and raise my family on the traditional ancestral and unceded territory of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations, and very, very happy to be here in British Columbia. So just starting, just to highlight that this is an international collaboration. So the trial was originally funded in the UK by the National Institute of Health and Care Research there. The overall sponsor is City St George's at the University of London, and is also being very strongly supported by Imperial and the National Perinatal Epidemiology Unit, which is a big clinical trials unit based in the University of Oxford. From the Canadian side, as Peter mentioned, we've been able to secure funding from CIHR, and the operational side of the trial in Canada is going to be run through the Popcorn Network. So some of you who were at the PERN annual meeting a couple of months ago, you would have heard a short version of this presentation. So just with some highlights. So I'm going to go into that in a little bit more detail today. So just a bit of an overview of popcorn. So some of you will be familiar with this sort of network of networks, but for those of you who are not, it sort of includes various sort of dimensions that, so I'll start here on the sort of top left-hand side. There's various content expert pillars, including maternal health, emergency medicine, inpatient medicine, which is represented by PERN, critical care and infectious diseases, and then various cross-cutting pillars, including patient engagement, data governance, biobanking governance, and knowledge mobilization. There's a number of projects, and that's all listed in on the website there. And the network operates across 16 pediatric hospitals in Canada, and has a lot of shared sort of core infrastructure. So the background to the trial, so there's no really good data on acute bacterial meningitis epidemiology in Canada. That's recent. I'll show you a study that was published a few years ago now, but based on what we can gather from different sources and doing a bit of a back of the envelope calculation, we've estimated that there's 150 to 300 cases per year in Canada in infants aged under 90 days of age. In previous Canadian studies, we've seen up to three-quarters with clinically significant sequelae and around 7% case fatality. So I think, one of the reasons why I'm interested in meningitis is this sort of, it's a really devastating disease. It's a lot of it is preventable through vaccines, but despite that, we still see a lot of really, really bad disease. And as we all know, these young infants at this developmentally critical stage, if they have a major insult to the brain, it's, really devastating consequences that can be lifelong. We know from, international guidance, including from the CPS, that dexamethasone is recommended for older children, but there's no good data in young infants. And so this is the study that I mentioned that was published in 2017 in pediatrics that was done by Picnic, which is one of our pediatric infectious disease networks. And there was 113 cases in this. This is a neonatal study, and you can see that around 60% of them were term infants. But we see them at all gestations. The other thing to highlight here is that most of them occur. This is all cases of acute bacterial meningitis. So a small number in this study occurring in the first week of life, most of them occurring later on. Around in this study, around half of them were infants presenting from home, and around half of them were infants who are already in hospital on the neonatal unit or such like, for example. And then you can see again in the study the causes. So around a third are E. coli, around a third were group B streptococcus, and then a bunch of other organisms. The median treatment duration was 3 weeks. So this has massive implications for hospital utilization as well, with 3 weeks of intravenous antibiotics. Very, very small proportion received corticosteroids, sort of highlighting that it's not currently recommended in this age group, and then a small proportion needing some sort of surgical procedure. And then again, you can see here in the bottom right the very common complications. So seizures in around a third, hydrocephalus, brain abscesses, ventriculitis, cerebral infarcts being the most common. So really, really bad disease. This is a more recent study that I was involved in. This was done it was a administrative database study done in Ontario, specifically looking at Group B streptococcus during infancy, so in the first year of life, and neurodevelopmental impairments, here denoted as NDIs, in the first 5 years of life. And so you can see in 770 cases of GBS, there was around just over 50 per 1,000 person years that had any sort of neurodevelopmental impairment, that you can see divided here into mild, moderate, and this is multi-domain, and the domains are listed here, including cognitive, motor, social, behavioral, and sensory. And I just want to sort of draw your attention to this last column, which is the hazard ratio, the increased risk from infants who had GBS compared with non-GBS controls. And you can see in terms of any neurodevelopmental impairment, around a twofold increased risk, and similar for the multi-domain. And a lot of that, was in the motor development. So that's where we see a huge impact with the sevenfold increased risk of having some sort of motor neurodevelopmental impairment. That's sort of a bit of a background to why we think this is important and why there's still a need to try and do better to improve outcomes for these babies. So the specific research question in the sort of standard PICO format, so the patient population is babies between 32 weeks and 3 months corrected gestational age with suspected or confirmed bacterial meningitis, and I'll sort of flesh that out in a little bit as to what that means. And the intervention is standard of care plus dexamethasone, using this dosing, so Q6 for 4 days, so a total of 16 doses, and the control is standard of care based on CPS guidelines without dexamethasone, with the primary outcome being survival without moderate or severe neurodevelopmental impairment at 24 months of corrected age. And I'll flesh out some of these things as we go in the next few slides. So first, the intervention. So in terms of benefits of steroids, so this is a recently published systematic review that shows in terms of hearing loss, this is all pediatrics, so clearly there's no data specifically in this age group, but you can see around almost 40% reduced risk of hearing loss with treatment with dexamethasone in older children. With neurological sequelae, it's less clear cut. It depends a little bit on the dose if you separate out the studies that use different doses, but at the dose being used in this study of 0.6 milligrams per kilogram per day, again, around a 40% reduction in neurological sequelae in these older children. In terms of safety, so this is a systematic review of corticosteroids in the prevention and treatment of bronchopulmonary dysplasia, of which I know very little. It's a long time since I did neonatology, but this was just to sort of consider what the potential risks of steroids might be in this population. And this is divided into systemic use early, and early for the purposes of this systematic review was in the first 7 days of life, and late, which is beyond that, and both with dexamethasone and hydrocortisone. In the first few columns are the sort of endpoints related to BPD, which I'm not going to talk about mainly because I don't know anything about BPD. But in these columns here are the safety outcomes that were looked at in these various studies, including cerebral palsy, psychomotor or mental developmental impairment, disability, blindness, deafness, and sepsis. And you can see while there's a lot of yellow boxes, so not reported, but there are mostly if you look in the top section with the early use of systemic steroids, there is a bit of sort of these red boxes, which is there's potential evidence of harm. If you look in the late use of steroids, it's all gray or yellow. So either no data or no evidence of any effect, either beneficial or harmful. And that has impacted some of the trial design. So just bearing in mind, again, this is early in the first 7 days, and with late steroids after the first 7 days of life, there's no evidence that it's harmful, at least based on this review. So then that's a bit about the intervention. In terms of the outcomes, the primary outcome, as I mentioned, is survival without moderate or severe neurodevelopmental impairment at 24 months of age, corrected for prematurity. In these various domains, cognitive, language, vision, hearing, seizures requiring medication, and gross motor impairment. And it's assessed using a combination of parent-completed questionnaires, and I'll talk about the main one that we're using for this on the next slide, and any data that we're allowed to get from the hospital charts. And this is all assessed by a blinded endpoint review committee. There are a whole number of secondary outcomes, which I'm not going to go into in any detail, but essentially relates to duration of treatment and length of hospital stay. This fourth bullet point here of GI hemorrhage, hypertension, hyperglycemia, and invasive infection relate to potential side effects of the steroids. And then a number of other neurodevelopmental endpoints and quality of life endpoints that are a little bit more granular than this overall primary endpoint. And in the UK, there's also going to be some additional data collection for health economic outcomes. So the main parent collected tool we're using to assess this neurodevelopmental impairment is called the Parker R tool. Interestingly, the person who devised it is one of the sort of external reviews of the on the steering committee. And so this is how this is divided into these different domains, as I mentioned. And then again, I'm not going to go through the whole table, but there's various cutoffs on moderate and severe impairment. And this is based either by a validated survey sent to the parents to complete, or in the case of something like hearing loss or seizures, information that we can get from the clinical data as well. And then the Blinded Endpoint Review Committee, or the BERC. So basically, for each individual case, the BERC committee will have the parent collected data from the surveys, any clinical data that is available, and acknowledging that that will vary from one case to another depending on how much follow-up they've had, or if the follow-up is at the tertiary center or at a local hospital, which may or may not be available depending on local ethics and other local systems. So we know that there will be some variability in that. Vision and hearing test results that are collected, and then a 24-month study form completed by the study staff. So the BERC will review all of that and then classify each child into moderate, severe, or no impairment based on any of those different domains that I mentioned on the previous slide, and they will form the final classification. So the goal of this is to have objective blinded review, standardized across all the sites. So the same BERC will review the data from the UK sites and the Canadian sites, and integrating both parent-reported data and clinically reported data to try and make it as reliable as possible and determination of the endpoint. So the overall, just very briefly, the trial design. So it's a multi-site, open-label, two-arm, parallel group pragmatic RCT, and happy to go into any further details of that if people have any questions afterwards. There's just over 1,100 babies that will be randomized with a goal of 60 sites in the UK, and they'll be doing the bulk of the participants, and then 14 sites in Canada, with 158 Canadian participants as the target population, and we're expecting to recruit from neonatal units, emergency departments, intensive care units, and pediatric wards. And then the participants get followed up to 24 months corrected age, and we're expecting that this is going to be quite a long trial given the sort of incidence of this disease. And so recruiting over 54 months starting from June of this year, running through to 2030. So these are the sort of more detailed inclusion criteria. So the first one, it looks complicated, but after much back and forth, this is sort of, we tried to make it as sort of simple as possible for people to figure out whether babies were eligible or not when they're seeing these babies at 3 a.m. on a busy shift. So for term babies, essentially, it's relatively simple. They can be included up to 90 days from their date of birth. For babies who are born from 34 to 36 plus 6 weeks, they can also be included up to 90 days, the corrected age in this case. For babies that are born younger than 34 weeks, they have to both be at least 32 weeks corrected age at the time of randomization, between that and 90 days corrected age, but they also have to be older than 7 days of age, which relates back to the data that I showed you on the potential risk of steroids in the first week of life in this preterm group. So that's where that has come into the eligibility criteria. In terms of the determination of suspected or confirmed bacterial meningitis, so they have to be clinically suspected and being treated for that. And then at least one of either this number one, which is totally clinical, so seizures or bulging fontanelle or altered consciousness. And then number two, based more on the biochemistry, so raised CRP, and either a raised CSF white cell count or CSF protein or CSF blood glucose. In centers that don't use CRP, then we will accept procalcitonin, and then there's various corrections for white cell and protein based on bloody taps. And then the microbiologic criteria include positive CSF gram stain or CSF PCR or CSF culture for the relevant bacteria. And I've got a slide, I think, somewhere with the relevant bacteria. So the exclusions are if the first dose of antibiotics is more than 12 hours prior to the administration of dexamethasone, which aligns with the UK NICE guidelines, which are the sort of most lenient in terms of the recommended interval between antibiotics and steroids. So we're really wanting to give the steroids within 12 hours of antibiotics. If the child's already on antibiotics and then the dose or the antibiotic is escalated because now there's a new suspicion of meningitis when perhaps there wasn't previously, then that sort of sets the 12-hour clock. Babies who are less than 34 weeks at birth within the first 7 days of life are excluded. Previous neurosurgical intervention or a shunt, hypersensitivity to dexamethasone, previous randomization in this trial. So if they've had recurrent meningitis and they've already been in the trial, they can't get randomized again, or if they're receiving palliative care, bearing in mind that the primary endpoint is at 2 years of age. We're planning to operate a deferred consent model, which has been universally accepted in the UK. And in our initial conversations with various research ethics board, we think will be accepted in most sites in Canada, perhaps not all. So also research without prior consent and justified by the emergency life-threatening nature and the timely need for steroid administration within 12 hours. And so essentially, if babies meet the criteria, they would be randomized before full informed consent to receive dexamethasone or not. And then this happens with other sort of pediatric emergency trials. The rationale is that, and this has also had feedback from our parent partners, that they're often too distressed to give informed consent, the dexamethasone wanting to be started as soon as possible, certainly within 12 hours, making it difficult to do a prospective consent. So essentially, the process would be randomization, usually after the LP, although you can meet the trial eligibility criteria without an LP. And then the goal would be to approach parents' carers, ideally within 48 hours, but any time up to the time of discharge. And then written informed consent, at which point they can still decide to withdraw from the trial if they so wish, or at any time, of course. Okay, and then this is a sort of overall table. So essentially, the enrollment involves eligibility, randomization, consent, either either immediately or a bit later if it's deferred. They then receive their standard of care plus or minus dexamethasone, which continues for 4 days. And then there's various clinical data collection, and then a number of questionnaires are collected during hospitalization. At the next sort of time point is 8 weeks. Post-randomization, and then at 12 and 24 months corrected age, and then adverse events collected throughout the study period. For those of you who are really into the stats, this is one slide on the stats. So the statistical analysis plan is a work in progress. There'll be the usual sort of descriptives, comparisons of normal and non-normal data with mean, standard deviations or medians interquartile ranges with no plans for significance testing for baseline differences as is standard for RCTs. And then the primary analysis will be an intention to treat for all analyses, with the reference group being the treatment as usual without dexamethasone and with dexamethasone being the intervention group. And then various statistical approaches, and the statistical side of it is being led by the perinatal epidemiology unit and their statistical team in the UK. And then there's various planned subgroup analysis based on bacterial versus non-bacterial meningitis. Obviously, we're randomizing these children very early. Some of them will end up having not having bacterial meningitis in the end. And so that will be a planned subgroup analysis as well as by a different pathogen type, acknowledging that some of these subgroups will be too small to reach a statistically significant conclusion for all of the endpoints. In terms of our various definitions, so confirmed bacterial meningitis is if you've got basically a positive culture or CSF PCR, that's the sort of easy one. If you've got an abnormal CSF white cell protein or glucose and a sort of neurotropic meningitis pathogen in the blood, then that also is confirmed. Or if you've got a positive CSF gram stain and a pathogen in the blood on culture or PCR. There's a sort of slightly more loose criteria of possible meningitis where it may be that you've got, for example, pneumococcus or a meningococcus in the blood and you didn't have an evaluable LP or a very high CSF white cell count over 500 without any pathogen identified. And then everything else is classified as non-bacterial meningitis, including definite viral meningitis, where there's a virus present in the CSF on PCR or an abnormal CSF white cell count and a virus in the blood on PCR. And this is based on, so Peter sort of referred to some of the studies that did in the UK before I came to Canada several years ago. And this is based on definitions that we used in a large study of 3,000 children with suspected meningitis in the UK. And for those of you who want to see the list, this is a list of what we're considering relevant bacterial pathogens for meningitis, and these are the list of the relevant viruses and a lot of the familiar friends or not friends there. In terms of patient input, there's a UK patient advisory group that has been set up specifically for this trial. There's also been input into throughout from the protocol design to all the materials that have been developed for recruitment and information and informed consent, etc., for the trial with the Meningitis Research Foundation in the UK and Group B Strep Support, which is a parent-led UK organization, Meningitis Foundation Canada, who we're just about to engage with, as well as the patient engagement pillar of Popcorn, which is led by Francine Buchanan. We're aiming to provide options for various materials in multiple languages, and we're working with the sites to identify which languages there should be and the best way to do that, as well as having both written and video recruitment and consent materials. And so I think this is the last slide, just with some of the details. So Paul Heath is the overall chief investigator of the trial based in the UK. The UK co-lead is Chris Gale, who's a neonatologist at Imperial. I'm the Canadian co-lead. And then we've got a really excellent team of lead investigators in Canada. A lot of Montreal representation, but that's all good. Representing the various networks that are part of Popcorn, as well as the Canadian Neonatal Network. And the study is sponsored by City St. George's at the University of London and the Canadian side by UBC. And that's the end of everything I wanted to say, and happy to have any questions. And I don't know, Peter, if you want to do that now or after Sanjay talks, I'm happy to do either.